Welcome to the Deep Dive, where we really try to unpack complex topics,
Yeah.
turn that dense info into something clear, something compelling for you.
Yeah, make it stick.
Exactly. Today, we're plunging into a subject that, well, it touches us all, but its dangers are often kind of hidden. Abdominal and urologic emergencies.
Mm-hmm.
Our mission. Take a stack of medical sources like, imagine an EMT textbook chapter and make it digestible. Fascinating, even.
It's definitely important stuff.
We want you to move past those vague worries,
Yeah.
get a really informed understanding of sudden belly pain and related issues.
It's a big area.
It is. We'll cover the basics, the anatomy, specific conditions, decode pain signals, and look at how emergency responders actually handle these things, even dialysis emergencies.
And what's really illuminating, I think, is just how common abdominal pain is. But figuring out the why, that can be a massive challenge, even for, experienced doctors. So this deep dive, it's not about self-diagnosis, not at all. It's about getting the core principles so you can really appreciate the seriousness, the urgency when these symptoms pop up.
Exactly, because we've all had a stomach ache, haven't we? A bit of indigestion.
Yeah.
But how do you tell if it's just fleeting or something way more sinister?
It's the million-dollar question.
This deep dive is kind of your shortcut to that awareness, those aha moments that make it all click, help you understand what's really going on.
Let's get into it then.
Okay, to really get what can go wrong inside, we need a quick tour first, the abdominal cavity. It's totally busy, right? Tightly packed.
Very much so.
Let's start with a really key distinction, solid versus hollow organs. Think solid organs like your liver, spleen, pancreas, kidneys, ovaries.
Right, the dense ones.
Yeah, and the crucial thing here, injury to these often means massive internal bleeding, shock, because they have such a rich blood supply.
Mm-hmm. That's the immediate danger.
And it's interesting, the kidneys, ovaries, pancreas, they're technically behind the main abdominal lining, retroperitoneal, but they definitely still cause abdominal pain.
Oh, absolutely. If we zoom out a bit, this solid versus hollow distinction, it really dictates the kind of emergency you're facing, often.
How so?
Well, like you said, solid organ injury, think rapid, potentially fatal hemorrhage. Hollow organ injury, that's more about infection, contamination.
Gotcha. So the hollow organs, that's your gallbladder, stomach, small intestine, large intestine, bladder.
Exactly. And the big risk if they get injured, perforated. Their contents leak out. Stomach acid, bile, waste. Yeah, it contaminates the whole abdominal cavity, peritonitis, which is really serious.
Okay, so let's quickly trace the journey food takes. Digestion starts even before the stomach, but the stomach itself is a major chemical breakdown zone.
Right. Then the liver, what a powerhouse. Makes bile for fat, filters toxins, stores energy, even clotting factors.
It does so much. And the gallbladder is just a little storage pouch for that bile.
Yep. Then the pancreas, it makes digestive enzymes and crucial hormones like insulin for blood sugar.
Okay, then food hits the small intestine, duodenum, jejunum, ileum. That's where most nutrients get absorbed, right?
Primarily, yeah. Then the large intestine, the colon, its main job is absorbing water, forming stool.
And the spleen, almost forgot, it's in there, but not for digestion.
Right, it's part of the lymphatic system. Filters blood, key immune functions, no digestion.
Okay, so now imagine these intricate systems. They go wrong. That's when we hear that term acute abdomen. Sounds serious.
It is. It's a medical red flag. It signals a potentially dire situation.
So acute abdomen, it's not one specific disease.
Exactly. It's more of a medical alarm bell. Means sudden, severe abdominal pain, often pointing to something serious, something progressive that needs immediate medical attention.
And often it's tied to peritonitis.
Very often, yes. That's the inflammation of the peritoneum, that thin membrane lining the abdominal cavity and covering the organs.
What causes that inflammation?
Basically, any foreign material getting into that normally sterile space, blood, pus, bile, digestive juices, anything that shouldn't be there irritates it.
Right, and that irritation, it sets off a cascade.
Precisely, a dangerous domino effect.
Yep.
It often paralyzes the intestine, that's called ileus.
Yeah.
The gut just stops moving.
So everything backs up. Gas, waste.
Exactly. Leads to painful bloating, distension, and often the only way the stomach can empty is vomiting. So nausea and vomiting are really common.
Okay.
And here's something critical. Peritonitis can cause a huge fluid shift. Fluid leaks from the bloodstream into the abdominal cavity.
Which lowers your blood volume.
Right. Reduces circulating blood volume, can lead to dangerously low blood pressure, even shock. And you might see a fever, but sometimes you don't, especially early on, which can be tricky.
It makes you wonder, why does the body react like that? almost self-destructive.
It's often a desperate attempt to wall off the problem, but the consequences, those fluid shifts,
Yeah.
they can escalate incredibly fast, life-threateningly fast.
And the pain itself,
Yeah.
it's not always what you'd expect, is it?
Not at all. That's a key point. We feel different kinds of abdominal pain.
Like direct pain.
Yeah, that's straightforward. You feel it right where the irritation is. Usually involves the outer lining, the parietal peritoneum. Its nerves are pretty good at localizing.
Okay. Then there's visceral pain.
Right. That's more of a deep, vague, poorly localized ache. It comes from the organs themselves, where they're lining the visceral peritoneum when they stretch or contract. Those nerves just aren't as precise.
And the really weird one, referred pain.
Ah, yes. Fascinating stuff. Pain from one organ is actually felt somewhere else entirely on the body's surface.
Why does that even happen?
It's the body's wiring, basically.
Yeah.
Nerve pathways from deep organs run close to pathways from the skin and the brain. Well, it gets confused. It interprets the signal as coming from the skin area.
Can you give an example?
The classic one, and this is a great aha moment, is acute cholecystitis, gallbladder inflammation. Where's the pain often felt?
The right shoulder.
Exactly, the right shoulder. It's not random. The nerves from the gallbladder are physically close to the spinal nerves supplying the shoulder skin. It's like crossed wires.
Wow. Okay. And that's different from radiating pain.
Yes. Radiating pain travels. It moves from the source along a pathway. Think kidney stone pain. Starts in the flank.
And goes down towards the groin.
Precisely. It follows a track.
Yeah.
So let's map this out a bit. Knowing these patterns is super useful.
Okay, lay it on us. Common conditions, typical pain spots.
All right. Appendicitis. Often starts vague, around the navel maybe, but the key is when it shifts and gets sharp in the lower right abdomen, plus that rebound tenderness pain when you let go of pressure.
Got it. Lower right. What about cholecystitis, the gallbladder one?
Pain in the right upper abdomen, often, but remember that referred pain to the right shoulder. That's a big clue.
Okay, ulcer pain.
Usually upper mid-abdomen, maybe the upper back, often described as burning or gnawing.
Diverticulitis.
Typically left lower abdomen, think lower left quadrant.
And AAA, that aortic aneurysm.
If it's tearing or rupturing, sudden severe tearing pain, often in the low back and lower abdomen. Really intense.
Cystitis, bladder infection.
Lower mid-abdomen, right behind the pubic bone usually.
Kidneys down again.
Intense flank pain, side or back, that radiates down towards the genitalia.
And pancreatitis.
Upper abdomen, often across both upper quadrants, and frequently radiating straight through to the back. You see, understanding these patterns, it really gives you insight, helps appreciate the challenge for doctors, but also gives you potential clues if you or someone else has these symptoms. You start to learn the body's language, even if it's a bit indirect sometimes.
Definitely gives you more to go on than just, my stomach hurts. Okay, so we've mapped the area, we understand pain signals. Let's dive into some specific common emergencies. First up, ulcers. Peptic ulcer disease.
Right. These are actual sores, erosions in the lining of the stomach or the first bit of the small intestine, the duodenum.
What causes them usually?
Mostly it's either infection with H. pylori bacteria or chronic use of NSA pain relievers, ibuprofen, aspirin, that kind of thing. Alcohol and smoking can make them worse, too.
And the classic symptom is?
That burning, sometimes gnawing, hunger-like pain in the upper abdomen. Often feels better right after eating, but then comes back a few hours later.
But they can get really serious, right?
Absolutely. The aha here is recognizing the danger signs. Vomiting blood that looks like coffee grounds, or having black, tarry stools that means internal bleeding, critical emergency. Or if the pain suddenly becomes excruciatingly severe, it could mean the ulcer has perforated, burned a hole right through. Life-threatening.
Okay. Next, gallstones and cholecystitis.
Gallstones can form, and if they block the gallbladder's exit, the gallbladder gets severely inflamed. That's cholecystitis.
And the pain.
Usually constant severe pain in the right upper or maybe mid-abdomen often refers, again, to the right upper back or shoulder.
Is there shoulder pain again?
Yep. It classically hits maybe 30 minutes after a fatty meal, often at night. Nausea, vomiting too. And interestingly, older adults might not have the full picture, maybe just localized tenderness.
Good to know. What about pancreatitis? Inflammation of the pancreas.
Can be triggered by a gallstone blocking its duct or often by alcohol abuse. The pain is severe, upper left and right quadrants, frequently radiating straight to the back.
Worse after eating.
Typically, yes. Nausea, vomiting, a bloated abdomen are common, and it can get bad, fast sepsis, hemorrhage. Very serious.
And there's appendicitis.
Yeah.
Super common cause of acute abdomen, right?
Very common. Inflammation or infection of the appendix.
How does that usually start?
Often vague, dull pain around the navel initially, but the big clue is when that pain moves and sharpens, localizing to the right lower quadrant.
And that rebound tenderness thing.
Classic sign. Pain when you press gently and then quickly release. Also nausea, vomiting, loss of appetite, maybe fever. Patients often curl up, fetal position, find it helps. If it ruptures, that's peritonitis, potentially deadly.
Okay, so those are specific organs. What about general internal bleeding? Gastrointestinal hemorrhage.
Right. Bleeding anywhere in the GI tract. It's a symptom, not a disease itself, but always serious. Needs checking out urgently.
And we talk about upper versus lower GI bleeds.
Exactly. Upper GI bleeding is from the esophagus down to the upper part of the small intestine. Causes could be esophagitis, those dangerous esophageal varices, swollen vessels from liver failure, or a Mallory-Weiss tear from severe vomiting.
How does upper GI bleeding show up?
Usually hematemesis vomiting blood, either bright red or like coffee grounds, and often melena, those black tarry stools because the blood's been digested.
And lower GI bleeding, further down.
Yeah, from the mid-small intestine to the anus, causes like bowel inflammation, diverticulosis, cancer, hemorrhoids. This usually shows up as bright red or maroon-colored blood in the stool. The color gives you a clue to the location.
You mentioned esophageal varices. Sounds scary.
They are swollen, weak blood vessels in the esophagus, usually from increased pressure due to liver failure, often chronic alcoholism. If they rupture suddenly, it's catastrophic. Massive vomiting of bright red blood, shock, can be fatal in minutes.
Wow. And the Mallory-Weiss tear.
That's a tear right at the junction where the esophagus meets the stomach, usually caused by really violent coughing or vomiting, also causes upper abdominal pain, vomiting blood.
Okay. What about something like gastroenteritis, stomach flu?
Yeah, basically an infection causing diarrhea, nausea, vomiting, often from contaminated food or water, bacteria, or viruses.
Main symptom is diarrhea.
Diarrhea is key. Can be really severe, leading to dehydration, even shock if fluid loss is massive. And here's that safety tip again. For certain types, like C. diff diarrhea, alcohol hand sanitizers do not work, need soap and water, gloves, chlorine cleaners.
Good reminder. Diverticulosis and diverticulitis. What's the difference?
Diverticulosis is just having these little pouches, diverticula, in the colon wall. Very common, often due to low fiber. It's actually a frequent cause of painless, bright red, lower GI bleeding.
Okay, so dirosis is just having them.
Right. Diverticulitis, the itis, means inflammation. That's when feces get trapped in those pouches, causing infection. That hurts.
Where does that pain usually hit?
Typically left lower abdomen, often with fever, maybe nausea, vomiting. If one of those pouches ruptures, big trouble, peritonitis, sepsis.
Got it. And lastly for this group, hemorrhoids.
Much more common, less dangerous usually. Swollen blood vessels around the rectum, often from straining, pregnancy, constipation.
Symptoms.
Typically bright red blood on the toilet paper or coating the stool, maybe itching, sometimes a painful lump if it clots. Usually not a major emergency, but needs checking if bleeding is significant or persistent.
Okay, phew. That covers a lot of the digestive side, but the abdomen holds more, right? Urinary system.
Absolutely. And problems there can definitely cause abdominal pain. Let's start with cystitis.
Bladder infection, UTI.
Exactly. Inflammation of the bladder, usually bacterial, very common, particularly in women, causes that lower mid-abdominal pain, sometimes blood in the urine, and that classic urgency and frequency feeling like you have to go all the time.
Can it spread?
Yes, if untreated, the infection can travel up to the kidneys, which is much more serious. Pyelonephritis.
Okay, then kidney stones. Renal calculi.
Ouch. These are crystallized chemicals forming stones in the kidney. If one tries to pass down the ureter, the tube to the bladder, it can cause a blockage and incredible pain.
Where's that pain felt?
Often starts as a vague ache in the flank, the side, below the ribs, but it can rapidly escalate to intense, agonizing pain that classically radiates from the flank down towards the groin.
Patients seem really restless with stones.
Very. They can't get comfortable. Often pacing, writhing, nausea and vomiting are common too, and usually a little bit of blood in the urine from the stones scraping the ureter.
What happens if the kidneys themselves fail?
That's kidney failure. The kidneys lose their ability to filter waste products from the blood, leads to a buildup called uremia.
Is it always sudden?
No. There's acute kidney injury, AKI, which is sudden, often reversible if treated quickly. But there's also chronic kidney disease, CKD, which is irreversible, progressive loss of function over months or years, often caused by diabetes or high blood pressure.
What does CKD lead to?
Eventually, end-stage renal disease, ESRD, requiring either dialysis or a kidney transplant to survive. Symptoms build up: lethargy, nausea, headaches, cramps, swelling.
And dialysis itself can have emergencies.
Definitely. This is crucial. When kidney function fails totally, dialysis is a lifeline, but it has risks. Patients use either peritoneal dialysis, PD, using the belly lining to filter, or hemodialysis, using a machine.
What happens if they miss a treatment?
Big problems. Fluid overload is a major one, can lead to pulmonary edema, fluid in the lungs, making it hard to breathe. Weakness, electrolyte imbalances, it gets serious fast.
And PD, the one using the abdomen.
Fluid circulates via a catheter in the belly. The main risk there, though small, is infection peritonitis. Causes abdominal pain, fever, the dialysis fluid might look cloudy, needs urgent treatment.
What about hemodialysis, the machine filtering?
Blood goes from the body through the machine and back. Most patients have a special access point created surgically, a shunt or fistula, usually in the arm. It connects an artery and vein.
And that's the arm you shouldn't use for blood pressure checks?
Absolutely. Critical safety point.
Yeah.
Never take a blood pressure on the arm with a dialysis shunt or fistula. You could damage it, cause a clot. Always use the other arm.
What other issues can hemodialysis cause?
Lots of potential things. Low blood pressure during treatment, irregular heartbeats, muscle cramps, altered mental status, even bleeding or infection right at the shunt fistula site.
Okay. So beyond GI and urinary, what else lurks in the abdomen?
One of the most feared emergencies, an abdominal aortic aneurysm, or a AAA.
The aorta, that's the main artery from the heart.
The biggest one, yes. In some people, especially older individuals, its wall can weaken and bulge out like a balloon. That's the aneurysm.
You feel it.
Sometimes a pulsating mass can be felt in the abdomen, but it's actually rare. And if you suspect it, you should never push hard or palpate vigorously. Be extremely gentle.
The real danger is rupture.
Exactly. If that weakened wall tears or bursts, it's catastrophic internal bleeding. Acute peritoneal irritation from the blood, hemorrhagic shock, extremely high mortality rate.
What are the symptoms of it tearing?
Often a sudden onset of severe tearing or ripping pain, classically radiating straight through to the back, sometimes described as flank pain too. It's often asymptomatic before it starts to expand or tear.
Like that case study patient, the 79-year-old.
Precisely. His sudden severe pulling apart, pain radiating to his lower back, signs of shock, the pulsatile mass, textbook expanding AAA. Thankfully, he got to surgery.
Key points for managing a suspected AAA.
Avoid vigorous palpation, gentle handling, gentle transport. Keep the patient calm. Anxiety raises heart rate and blood pressure, making it worse. And crucially, do not elevate their legs like you might. For other shock, it can actually worsen the situation by increasing pressure.
Wow. Okay. What about hernias?
That's when an organ or tissue pokes through a weak spot or opening where it doesn't belong.
Like in the groin.
Groin is common, yeah. Can also happen at old surgical sites or be congenital.
Are they always dangerous?
Not always. If it's reducible, meaning you can gently push the bulge back in, the risk is usually low. But if it gets stuck out, that's incarcerated.
And the worst kind.
Strangulated.
Yeah.
That's when an incarcerated hernia gets squeezed so tightly that its blood supply is cut off. The tissue starts to die. That's a major surgical emergency. Needs immediate operation.
Warning signs for an urgent hernia problem.
If a previously reducible hernia suddenly can't be pushed back in, if there's significant pain or tenderness at the site, or if the skin over the hernia turns red or bluish, those mean get help fast.
Okay. Now, does everyone experience these things the same way? You mentioned older adults earlier.
Right. This is super important. Patient context matters hugely. Geriatric patients, older adults, often present atypically. Their pain sensation might be dulled. They could have a raging infection or a serious bleed but report only mild discomfort or even none.
So they might not seem that sick.
Exactly. They might not show that classic abdominal rigidity or guarding you see in younger patients. And their temperature regulation is off, so they might have little or no fever even with severe peritonitis.
What else causes belly pain in older folks?
Sometimes it's cardiac related, believe it or not, or severe constipation, bowel impaction, or obstruction, which can be life-threatening in itself. All this means there's often a delay in them seeking help or the problem being recognized. You have to ask detailed questions: recent illness, bowel habits, fluid intake.
What about kids? Pediatric patients?
Assessment is really tough there. A young child often just says, "My tummy hurts." Doesn't give you much detail.
What causes belly pain in kids?
All sorts of things. Infection, something they ate, poisoning, you have to look for clues. Even things like spider bites or metabolic problems like diabetic ketoacidosis can present with abdominal pain.
So the takeaway for kids.
Because assessment is so difficult, it's always the safest bet to have a child with significant unexplained abdominal pain evaluated properly by a healthcare professional. Transport is usually advised. It just highlights that critical point, doesn't it? What's textbook or typical might be completely different in older adults or children. Requires a high index of suspicion, really careful questioning.
Absolutely.
Yeah.
So given all this complexity, what's the role for, say, an EMT who arrives on scene? They can't possibly diagnose the exact cause right there.
No, and that's not their job. The EMT's role is absolutely crucial, but it's different. It's about rapid recognition of life-threatening conditions,
Okay.
providing prompt emergency care to stabilize the patient, offering emotional support, but not determining the definitive diagnosis. Their key focus is identifying the severity, looking for signs of shock, internal bleeding, severe infection, and getting that patient rapidly to the hospital where diagnosis can happen.
So let's walk through that approach. It gives us a good framework. Starts with scene size up.
Always. Safety first. Standard precautions, gloves, eye protection, maybe a gown if there's vomiting or diarrhea. Look for clues about what might be going on, any trauma. Any telltale odors, like from GI bleeding?
Then the primary assessment. ABCs.
Yep. Airway, breathing, circulation. Treat life threats immediately. Check their level of consciousness. How are they positioned? Knees drawn up often means abdominal pain. Is their breathing okay? Pain can make breathing shallow. Give oxygen if needed.
Circulation check.
Look for major bleeding, asking about vomit or stool. Check pulse rate and quality. Skin signs, pale, cool, sweaty, often means shock. And remember that crucial check for suspected AAA, feel for pulses in both feet. A difference can be a sign. Look for bruising on the abdomen.
And if they seem to be in shock?
High flow oxygen, lay them flat. Unless AAA suspected, then keep them flat but don't elevate legs. Keep them warm and urgent transport. Get moving.
After the ABCs, history taking.
If they're conscious, yes. Sample history, signs, symptoms, allergies, meds, past history, last intake, events leading up. Ask about specific meds like NSAIDs, antibiotics, alcohol use.
And those specific Urologic questions.
Right. Nausea, vomiting, how much, what color, blood, bowel habits, constipation, diarrhea, black stools, red blood, urination frequency, pain, color, odor. Use OPQRST for the pain onset, provocation, palliation, quality, region, radiation, severity, timing. For women, last menstrual period is vital. And remember, nothing by mouth.
Okay. Then the secondary assessment, the physical exam.
Patient's position gives clues, like we said. Look at the abdomen distension, bruising, scars, pulsating mass. Don't poke it. Then gentle palpation.
How is that done properly?
Explain first. Patient supine, knees bent if possible to relax muscles. Ask where it hurts most. Then palpate gently, clockwise, starting in the quadrant after the most painful one and ending there. Feel for tension, guarding, or softness. Watch their face for grimaces.
Rebound tenderness assessment.
Assess very cautiously if needed. It's pain on release of pressure, indicates peritoneal irritation, and vital signs, remembering that rule.
No BP cuff on the shunt fistula arm for dialysis patients.
Correct.
And finally, reassessment.
Absolutely vital. These conditions change fast. Recheck vital signs, level of consciousness, pain level, skin. Are interventions helping? Keep monitoring constantly, especially during transport. This whole systematic process allows EMTs to spot the danger signs quickly and get the patient the definitive care they need.
You really can see how, even without knowing the exact label for the problem, these steps are all about spotting the severity and getting help fast. Our own observations, as bystanders or potential future providers, they're so important too.
Absolutely. Being observant counts for a lot.
Well, we have covered an incredible amount of ground today, really peeled back the layers on abdominal and urologic emergencies, from organ basics to pain signals to red flags. Hopefully you feel you have a much deeper understanding now.
Yeah, it's complex stuff.
And while pinpointing the exact cause is tricky, even for pros, the key takeaways are recognizing those life-threatening signs, understanding how pain can present differently, and knowing that prompt, gentle care is crucial.
It's truly remarkable, isn't it, how a simple stomachache can actually be a signal from so many different body systems, each telling its own story of distress. Really drives home how interconnected everything is.
It really does.
And the need for vigilance, for timely response. It's critical.
All right.
Which leads to, I guess, a final thought, a question maybe for you listening. In a world where it's easy to just dismiss discomfort, maybe pop an antacid, How does this deep dive change how you think about listening to your body? Or listening when someone else expresses abdominal pain? What might you notice differently now?
That's a powerful thought to end on. Thank you for joining us on this deep dive into abdominal and urologic emergencies. We really hope you feel better informed, maybe a bit more prepared. Join us next time for more interesting